Hello, I am Dr. Pham. I am an assistant clinical professor at the University of Utah in the Department of Neurology in the Division of Headache and Neuro-Ophthalmology. And today for ENIGMA-U, we will be talking about an introduction to headache, a huge field within neurology. And so here we go, we'll dive right in. So the objectives for today will be to review major categories of headache disorders, review common primary headache disorders, review red flags for secondary headache disorders. We'll go over an overview of the workup when a secondary headache is suspected. And we'll do an overview of treatment options for common headache disorders. So there are major types of headache disorders. They can be divided up into the primary headaches, which are effectively headaches that are caused by themselves. They don't have any underlying cause. The secondary headaches, where there is an underlying cause. And then there's the neuropathies and facial pains and other headaches. So common primary headache disorders include migraine, tension type headache, trigeminal autonomic cephalalgias, and there are many others. Migraine, we typically think of as pain that is one-sided, or what we call unilateral. It is pulsing in quality, it's moderate to severe in intensity, and worse with physical activity. These headaches tend to last between 4 and 72 hours. In children, they can be shorter, around 2 hours. They're associated with nausea and or vomiting, or they can have light and sound sensitivity. They can come with aura. Visual is the most common. So this zigzag line that is on the side of the screen here is an example of what we would call fortification spectra, which is effectively a term we use for zigzag line, and it is one of the types of visual aura that we see. People actually see that kind of zigzag line often in rainbow kind of colors in the kind of side of their vision. Some other people will have like a smudge that comes over the vision and it kind of grows and expands, or sometimes it's crescent shaped, and it goes away. The aura usually lasts, well, it can last anywhere between 5 minutes and an hour. A lot of people say it lasts around 20 minutes. And there are some genetic forms of migraine that come with one-sided weakness, and we call that type of migraine hemiplegic migraine. So then there's tension type headache, and in tension type headache, the pain is usually on both sides. There is a pressure or tightening sort of quality of the pain. The pain is mild, maybe moderate, and it's not worse with physical activity. And there's usually not, well, there should be no nausea or vomiting, but there's usually no light or sound sensitivity either. So we call this the featureless headache. Then there's the trigeminal autonomic cephalalgias, which is a class of primary headache disorder. And these are one-sided headaches, and they have in association with them what we call cranial autonomic symptoms, and those should occur on the same side as the pain. The cranial autonomic symptoms that we see include conjunctival injection, which is a bloodshot eye, lacrimation, or otherwise known as tearing, nasal congestion, rhinorrhea, known as a runny nose, eyelid edema or eyelid swelling, forehead and facial sweating, miosis, which is a small pupil, and ptosis, which is a droopy eyelid. There also comes with these headaches a sense of restlessness or agitation, and the different types vary based on their length and frequency. So the different duration and frequencies of these attacks are shown in this graphic. So there's one called Sunct and Suna that tends to be about 1 to 600 seconds long, and there are at least one attack per day with this type of headache. Paroxysmal hemicrania should last between 2 and 30 minutes long, and there should be more than 5 attacks per day. For cluster headache, these should last about 15 to 180 minutes, and they should occur at least every other day, up to 8 attacks per day. And cluster headache tends to occur in cluster periods. And so a cluster period would tend to be about 1 to 2 months long. And then there's hemicrania continua, which is more of a continuous attack. So then there's the secondary headaches. These are headaches due to another underlying cause, such as high or low cerebral spinal fluid pressure, tumors, vascular or blood vessel abnormalities, complications of pregnancy, head trauma or whiplash injuries, infection, substances, or withdrawal from substances. And what we want to know the most about secondary headaches is an approach so that we don't miss them. So if you are seeing patients and somebody has come in with a concern about headache, one of your first jobs is to establish from their history or their exam if there are any red flags. If there are no red flags and they seem to fit the criteria pretty well for one of the primary headache disorders, then they probably have a primary headache disorder. But if they have a red flag, then we should really be thinking about secondary headaches. And when we think there is secondary headache, then we usually want to do additional testing. If we find a cause, then we know this is a secondary headache due to whatever that cause is that we found. If we don't find a cause, then maybe this is a primary headache and it just doesn't behave quite as typical as they usually would. So the headache red flags, the SNOOP 4 mnemonic is a great way to remember this. SNOOP for red flags effectively. So the S would be things like systemic symptoms, which means the whole body. So things like fever, night sweats, chills, weight loss, jaw pain. We would be worried about things like brain tumor or inflammation of blood vessels with those symptoms. The N standing for neurologic signs or symptoms. So any stroke-like symptoms, confusion, double vision, dim outs of their vision, ringing in the ears. These could signal a brain tumor, high cerebral spinal fluid pressure, stroke. And then we have the O for onset. So thunderclap, and we think, like a clap, a headache comes on just like that. That worries us about brain tumors, brain bleeds, blood vessel spasms, blood clots. The second O is for older, so people that are over age 50 that have new onset headache or headache that is worsening. We worry about brain tumor or inflammation of blood vessels. The first P is for positional. So if the headache is worse, either flat or upright, that worries us about the CSF pressure being either too high or too low. The second P is for prior history. And this one really is if there's a change from their prior headache history, that should ring the alarm bells. And then we would worry again about brain tumor, brain infection, such as encephalitis. The third P is pregnancy and postpartum. This would be a new onset headache during pregnancy or change in prior headache pattern during pregnancy. And we would worry for this about things like blood clot, blood vessel spasms, pituitary problems, stroke, and preeclampsia, which is a problem during pregnancy with elevated blood pressure, among other symptoms that come along with it. And then the fourth P is that it's precipitated by Valsalva. So Valsalva is that thing that happens where, like, if you bear down or you were to lift something heavy or cough or sneeze, it increases the pressure in your abdomen. And so we would see worsening of headaches with those sort of things like coughing, sneezing, bending, straining. That would worry us about something such as brain tumor or Chiari malformation. So if we suspect a secondary headache, then we kind of want to know what we would do to work this up. So usually we get some form of imaging, usually an MRI of the brain, which gets a really good look at the brain tissue. We also get an MRA, which is an MRI effectively that instead of looking at the brain tissue, focuses more on the blood vessels in the brain. And we also look at the blood vessels leading up to the neck. And then if we're worried about there being too low of spinal fluid pressure, then we might get a whole spine MRI to look to see if there's a place where spinal fluid is leaking. If we're worried about either infection or we're worried about pressure being too high, then often we will do a lumbar puncture, or you also may know this as a spinal tap. This is where we insert a thin needle into the low back, and when we have found the spinal fluid, we measure the pressure, and then we collect some of that fluid and we can test it to see if there's any signs of infection or inflammation. And then often we also will refer patients to our colleagues in ophthalmology, or effectively an eye doctor, somebody who's gone to medical school and has eye doctor training, and they would be able to look in more depth at the nerve in the back of the eye and the vision out in one's periphery, and get a really good sense of how this person's vision is. And the reason we do this is because some types of headache problems that cause headache can also cause vision loss. And so we don't want that to happen. And then there's some basic principles of headache treatment. So if you think about kind of a pyramid with the foundation as your base at the bottom, and then other things we build upon on top, we think about lifestyle as your kind of foundation. So things that we think about that help with headache prevention, or just treating headaches in general, is being really consistent and predictable, like going to bed and waking up at the same time each day, staying well hydrated, eating at consistent times during the day, managing stress levels, getting exercise, and then, maybe avoiding caffeine, or if you have caffeine, having the same amount at the same time each day, but always in moderation. So that's your foundation. Then we build upon that with our other treatment strategies. So prevention generally is thought of as something that you're doing every day, with a few exceptions, but for the most part, something you're doing on a day in and day out basis that's intended to reduce how frequently you have headaches and to reduce how bad they are when you get them. And then we have the other side of things, which is when we do have a bad headache, what do we do in the moment to try and help calm that headache down? Those are our acute treatments, and those are taken on an as needed basis. So some treatment options that we have for common headache disorders when it comes to prevention include antidepressant medications, antihypertensive. So these are medications that either lower blood pressure or heart rate, anti-seizure medications, CGRP targeted therapies. These are newer. These have been available since about 2018, and they block a molecule called calcitonin gene-related peptide that we know is elevated during certain types of headache attacks. Those have been a really interesting and promising newer medication that we have. We also have procedures that we do, things like Botox for migraine prevention. We can do nerve blocks, trigger point injections, or sphenopalatine ganglion blocks, which entails using a local anesthetic. Either lidocaine or bupivacaine is commonly used. So kind of like Novocaine, if you've ever had that given to you at the dentist. It's a numbing medication, and we inject it in an area where either a nerve that could be irritated during a headache is, or into some of those tight muscles that people often have with their headaches, and help to kind of do a nice reboot as a nice reset there. So sometimes that can be really helpful for people. There are neuromodulation devices, various different ones that can either be worn on the forehead, around the head, back of the head, one that does pulses to the neck. There's actually an armband one that you can wear. So all of these can be used as well. And then things like complementary and integrative medicine, so several vitamins and minerals, magnesium, vitamin B2, also known as riboflavin, coenzyme Q10, and feverfew. And then things like acupuncture can be used. And then on the acute side of things, so again, these are the what do we take as needed when a headache does come on. We can use several different types of medications. There's the NSAIDs, or non-steroidal anti-inflammatory drugs. For example, ibuprofen, naproxen, analgesics, such as Tylenol. There's a class of medication developed more specifically for migraine called triptans. You may have heard of the medication Imitrex or sumatriptan. That's one of them. There are actually 7 different triptans out there. There's a class called ditans that's very similar to triptans, but a little newer. That drug is called lasmiditan, or Rayvow is the trade name. There is dihydroergotamine, or DHE. There's a newer class called GPANTs, which blocks that molecule called CGRP that we talked about in the preventive medications. These ones are Nurtec and Ubrelvy, and there's actually a brand new one that was just approved by the FDA called zavegepant that is a nasal spray. There is butalbital, containing medications of Fioricet or Fiorinol. These medications are less preferred because they're a little more prone for medication overuse headache, and they have to be withdrawn slowly, safety wise. And so we prefer some of these other medications that we've mentioned as they're just a little better and a little safer. Neuromodulation devices also can be used for as needed treatment. And then we often use anti-nausea medications too, some to help with nausea, but some also can help with the headache. These ones that have a star by them, so the butalbital, dihydroergotamine, triptans and ditans, NSAIDs, analgesics, all of these, if they're used in any combination more than about 10 to 15 days per month, can actually cause worsening of headaches, something we call medication overuse headache. And so you do have to be careful how often those are used. And if they are starting to be used close to that amount of days in a month, then usually that tells us that we should ramp up our preventive treatment strategy. And so that's kind of in a nutshell, though, how we approach headache treatment. And that is all that I have for you guys. And so thank you very much for your time.